Welcome to the iCARE scenarios. We have been running iCARE for a long time, and I start every day off with scenarios, with one of these scenarios and a discussion from everyone. So I look forward to having a similar experience with you. And the feedback we've had for years with iCare is people wish, so the students are, I said, I wish that this type of scenario could be available. And I am finally getting around to being able to do this. And I didn't want to start this without being able to do monthly, like every month. You got to be consistent. I found that with the podcast, and we are now at 190 weeks of podcasts. We've not missed one, so we need to keep that going. So I wanted to try this out and see how you guys like this style. It's a bit limiting because with our quorum conversations, the three of us have kind of an open chat and everyone can talk, and we keep that within quorum students and members of the quorum. But I wanted to respond to the feedback that we get every iCare. So iCare is intensive care for austere and remote environments. I created this as part of both the master's program and the bachelor's program. And it's a CPD course. So it's a 5-day CPD that you're welcome to come to Pretty Bay, Malta. Just have a go at that. You don't have to be enrolled at all. But my passion for starting this was having more advanced skills, clinical acumen to deal with the critical casualty. As a basic paramedic, I had a pretty good idea of trauma and maybe a little medical. Don't talk to me about peds or geriatrics. And then as I progressed and became a little better with critical care, I just realized that we needed a bit more clinical backing for some of these really critically unwell casualties. And prolonged casualty care, prolonged field care definitely deals with that. And there's no way for me to not teach without including that and improvised medicine. So let's go through this and let's see how it works. So here is a scenario. This is Monday scenario for our iCare. So you are working as a remote medic in a seismic survey ship in the Indian Ocean. Let's walk through this. You get your bag because this guy, you get a call of casualty has had diarrhea for the last 24 hours. He's in the tub. You can't, I mean, he's not going to come to your clinic. So you go to his clinic and this is his presentation. And no, he did not have pants on. He had a shirt only. So what are your first concerns as a medic, a doc, nurse seeing this patient? Type something into the message board. Alfredo, dehydration. Absolutely. Anyone else? Electrolyte and balance. Yep. Safety, because what is this a infectious agent? We're at the college. We're really big in tropical diseases. So is this a possibility of some really bad thing coming? Shock, definitely. Hyperkalemia, cholera. So and then safety, ABCs. Is this person infectious? So cholera. So that's something that we definitely like to have as a differential diagnosis. We'll get to that. But one of my mentors, I worked for Dr. John Hagman at Deployment Medicine International for about 7 years. And his saying with cholera is when you walk into the room and there's poo on the ceiling, it's cholera. It's cholera. It's 100% cholera. And that means just that there's poo everywhere. This guy doesn't have poo in the ceiling, and he is making it at least to the toilet. So let's continue on. And so we have you already have more than 5 differential diagnoses, which is a requirement for quorum that you must have 5. But what's your next action? Yeah, so we definitely need more history. BP will get our primary and secondary vital signs, ABCs. We get sample in a second, but what am I looking for? Am I going to touch this guy? Yeah, there we go. Andrew, Don PPE, Brian PPE, definitely. I'm having a mask as well as my gloves, possibly an eye shield, depending on the level of the situation. So this is our primary vital signs and our CABC. At the college, we go with CPRO as our primary vital signs. And the reason we do that, it only takes an SpO2 monitor, which we all have. It takes a second to get on. And then immediately we have a very good picture of this casualty's cardiovascular status. And then on top of that, we can do cap refill. And we'll do that in the sternum. Why do we do that in the sternum? Always at the sternum. Why? It's a warm place, consistent core temp, doesn't, get exposed to the out of doors, so even if you're on the side of a mountain at 3,000 meters, you can at least get your thumb in there and do a refill test, cap refill test on the sternum. So the fingertips, we don't even bother. Don't even do it unless I wanna compare, but, eh. So his C Pro is there, and we look at a quick CABC, no CAD-HAM, no airway problems, breathing is normal, no bleeding, skin is pale, cool, and clammy, and you do feel a radial pulse, so good. We have a BP, and we can no longer say BP of 90, that's long since gone. Radial pulse doesn't necessarily mean that, but what I'm really looking at is my C Pro. C Pro. Now, is this guy big sick or little sick or no sick? Just from C Pro, we can see this. All right, little sick. I'm all right with that. He's definitely unwell. Is he critically unwell? Not yet, because he's still, well, let's get a BP to see if he's in shock. But so we have some red flags. Red flag is pulse rate and cool clammy. So a couple red flags. So he's little sick. He's not getting to my clinic, so I had to come to him. So he's sick, unwell, poorly, but he needs some help. So we are going to continue on with our D disability and E environment. So he's in a warm room and he is A in the AVPU and his pupils are equal round reactive to light and accommodating. So that's always good to have. And we will continue on to get an assessment of our last patient assessment. So at the college, we have CABCDE, just like everyone else. But we have added F, G, and H. And it's not just to prove to any Marines out there that we can say our ABCs, which is always a good thing. I designed this because it forces you to get your full set of vitals, document, but most importantly, you have no choice whatsoever but to immediately roll over to Hitman. And there's some discussions that I'm having with Sean Keenan and Jamie Reesberg about the failure of moving from March into Hitman. And people are getting March again and again. Oh, finish March. Let's do another March. And they refuse to move on to Hitman and sheet vomit. So at the college, we have no choice. We finish our CABCDEFG and then we roll over to prolonged casualty care. So here is our primary vital signs, and now we have our secondary vital signs. We use the word beast just to keep things in order, and I finally have a BP. Now, what I do with critical care is when I get a BP, I stop and I could be in a scenario and say, all right, whoa, 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 whoa. We have a BP. What's the map? And between map and urine output, that's your austere critical care. And yes, I know you critical care docs out there, nurses are going to be like, well, it's more. Yes, of course it is. But if I have a map above 65 and I have a urine output more than 50 mils an hour, I know a tremendous amount about my casualty. So my challenge to you, we have 112 over 72. Give me a map. Mean arterial pressure. Type it in. Boom, Andrew, you're already there. Anyone else? There's many different ways to calculate this out. So I'm lazy, and I'm also very, very bad at maths. So I don't do the 1/3 divided by 3 quadratic formula multiplied by pi or whatever it is. I take this number and subtract this number, and that's my pulse pressure. And so I'll have that pulse pressure, which here is 40. I'll divide that by 3, which is 12, and then I'll add 12 to this. 72 plus 12 is 84-ish. And Andrew, you had 85. Good. So we have a map bigger than 65. Awesome. And we need to get a urine output. We're still waiting on that. Any other red flags here? Go ahead and type it in. Yep, Alfredo, he has a temperature. So according to soon to be Dr. Jason Jarvis, if you have a temperature, what does that mean you have? Infection is good, but we're looking for malaria. Absolutely, Trent. So if you have someone with a fever and you're in the tropics or they traveled through the tropics or they read a book on the tropics, they have malaria and 100% chance of having malaria until you get 2 different RDTs to prove that they don't. And the reason at the college why we are so hell-bent on this is people are still dying from falciparum malaria because they're not catching this. No one should die from malaria. So he has 38. he has malaria until we have RDTs. RDT, so our differential diagnosis will definitely be malaria. Everyone all right with his sugar? That's over 4-ish, fine. A&O times 4, that's good. Sinus tachy, yeah, because he's got a high pulse rate. What about this? So this is a red flag, isn't it? You have pain in the belly, but we're still waiting on the lactate. We can get a blow by EtCO2 eventually, but we're not in our clinic yet. So what's next? What are we looking for? Good. Alfredo, we need a abdominal assessment, which in our field guide in the yellow section, we have a really good abdominal assessment. We'll show that. Trent, yep, 3-lead because of I carry a 3-lead that's literally this big and everyone gets a 3-lead. You sneeze, you get a 3-lead. Why not? We'll look at pain here in a second. Let's get our sample. So his statement is, I have been throwing up and I've had diarrhea all night long. A good question on, has he had a wee? We need to know that and we need to measure it. But he's been vomiting and he's had 3 episodes of diarrhea, a 7 on the Bristol scale. And we can trend this as well. So we can trend, that's our baseline now for the Bristol. Let's see if we get better or worse. No chest pain, no shortness of breath, or no occult blood in the stool. And until we measure this with a urine dipstick or a guaiac test to make sure that we don't have fecal blood, we still could have blood. But he's allergic to penicillin, who isn't at my age anyway. Past medications, he's a muscle-bound creatine type, multivitamins, fish oil, nothing red flag. Someone my age, it's going to be 4 times that length of the whole bunch of LOL drugs. So he had shoulder surgery. Yeah, not too worried about that. He tried to have coffee and toast. And you know that this patient and the 2 before him that you've seen has eaten shrimp last night. The patient works in the office and he was filling out paperwork in his office before the vomiting and nausea and diarrhea began. And he came back from a vacation in Jamaica a month ago. Any red flags? Could be an outbreak. So we got more than one, don't we? So no one has been as bad, but you've just had my belly hurts. So in a ship, it could be a whole bunch of different things. And we'll have a diff diag here shortly. Could be seafood. It could be, any of the viruses. So once we get down to D, and disability. So CABC, D disability. Disability is fractures and muscle problems, yes, but D is also diagnostic tests. So Trent, you already said 3-lead. This is my happy face. Well done. What other diagnostic tests do you want? Stool test, good. Malaria test, urinalysis, venous blood gas, that'd be nice. Dipstick for blood and in the fecal matter, and a dipstick for the urine. Why not? Any other toys you want to play with? Blood cultures would be lovely. Absolutely. We need blood cultures. Not many ships have that. Well, cruise liners. We had a podcast yesterday with a couple of cruise line doctors that would indeed have blood test. Ultrasound, excellent. Point of care lactate with an EPOC instead of an iStat, definitely. Because EPOC, you don't need to have a refrigerated cartridge. Ultrasound, this is my happy face. Well done. Ultrasound, everyone. You sneeze, you get an ultrasound. Awesome. So let's take a look here. So we have a rough differential diagnosis. You guys put a lot more out there, but let's look at what tests we can use to start knocking out these differential diagnoses. So you guys nailed it. We talked about urine dipstick for fecal occult blood, as well as urine blood, RDT for malaria, and lactate for sepsis. Did I miss anything? Andrew Reeve, you already said that. Well done. I didn't put ultrasound on here. I got to change that. All right. So here are the results. So there's no blood in the stool that you can see. RDT came back negative and lactate's 1.1. Anything below 2, and I'm happy. Anything on the urinalysis for blood would be a big red flag, either from the fecal matter or from the urine. Now, we need to do a malaria test, RDT. We need to do 2 malaria RDT tests because these tests are awesome. They're 95% accurate. The Binax now is 99%. I'm not willing to let 1 out of 100 of my patients die a horrible death of malaria because of that 1% chance of failure. So I'm going to use 2 that look at 2 different types of protein on the falciparum plasmodium. So HLD2 is one of them, and ALD, I think, is the other one, if I can remember correctly. So you get 2 different RDTs to look at 2 different proteins that will then be able to just double check. They're both about 95% accurate. So both of them together, I have a pretty reasonable success rate on making sure this guy does not have a line right here, which would show falciparum. I definitely need a line here as well. The good malaria tests will also have a PPAN, and a PPAN line means all the other malaria as well. So I definitely want to have some good RDTs. So in our field guide, page 42, we have abdominal assessments, and on at the bottom of this is 42, and the top on the bottom would be a second half of this. But so we came up with Dr. Germs as just a way to remember some of the problems we're going to see with the abdominal assessment. And here on page 124 is the referred pain map. So we got off of Wikipedia. So if you have a pain here, Alfredo, you and I had that exam this weekend with the AMLS. The pain here refers up here. That's going to be gallbladder. Or if it's pain that refers to the back, it could be cardiac. And this casualty has diffuse pain everywhere, not individual locations. So that's telling us something. So during our CABCD, we have different the disability, which is broken bones and things like that. But we also have diagnostic tests, and then we have our differential diagnosis. So you guys have thrown out a lot of good options, but let's go with a bacterial diarrhea. So let's move forward here. So I want some red flags on abdominal injuries, and this is in our field guide as well, on things that I need to maybe start thinking about evac criteria. If there's blood in the vomit, blood in the stools, and especially if it's really hard black blood, distended abdomen, pain and palpation, a silent belly would definitely be a big red flag as well. So diarrhea is common, and this one being infectious is easy enough, but diarrhea, for if you want to work in austere environments, which everyone's here because you want to, this is our main one of the main things we need to be very good at. So let's talk about diarrhea. Diarrhea is 3 or more stools per day, and it usually resolves within a fortnight. If you have chronic diarrhea, it lasts longer than a fortnight, and we use Bristol stool chart to trend. Diarrheal deaths every year is still over 1 million people die. Most of them infants die from diarrhea, cholera, as well as other diarrheal illnesses, and none of them have to die. Zero people in the world need to die from diarrhea if you rehydrate. So you have 2 options in life. You can hydrate or you can die, and you need to hydrate your casualty. So this here is a minimum better best from the Prolonged Field Care Working Group. I like it. It's wrong. It's wrong because this oral rehydration should be the best. And you should always go with oral rehydration first. If that doesn't work, then you do your IVIO. If that doesn't work, then you can do, well, I do subcutaneous. And if that didn't work, I do rectal. And I put on LinkedIn about a month ago a good hydration ladder, and I need to do some published research on that, showing that this works. Oral hydration is first, and you need to make sure that everyone can hydrate orally. Let me ask you, and I know the nurses in the group will be the first one to answer, but this person is not swallowing. How are we going to hydrate this guy if we don't want to use IV bags? Good. Antiemetic. What else? Sean, yep. Oral hydration is 250 mils every 15 minutes. And that's basically because it's the gastric emptying capacity. Your pyloric sphincter, that it's anywhere from 800 to 1200 mils per hour. So you can slam in more water than that. You're just going to dilute things. So the maximum is 1 liter an hour, and you need to make sure you do that over every 15 minutes. So nurses, what is the best way to hydrate this guy? Well, Mohammed, yeah, the rectal and subcutaneous is the go to hell option, but this guy can take oral rehydration. How are we going to do that? Buccal, yes, okay. Buccally, you can absorb fluid, but it's not going to be 1 liter an hour. There we go. Lance, well done. This is my happy face for you there in India, giving the right answer. NG tube works, right? So he has nausea and vomiting. You can do an NG tube. And somebody said give ondansetron or something like that. Awesome. Absolutely want to do that. If you don't have that, like diphenhydramine will calm them down a bit. You got to get an NG or an OG in and just do your 50. Yes, he's going to lose some of that from vomiting, but you're going to do the best you can to get that 15 or every 15 minutes, 250 mils. Good. Let's talk about diarrhea. And this is Something I heard from a tropical medicine conference in Hamburg, which I hope to get to that again this August. Question: what field options are readily available to make that more acceptable to the patients? If you have an NG tube, you don't have to worry about that because it's not the taste thing. Oral rehydration tastes awful. In fact, there was only one time in my life that oral rehydration solution tasted like milk, and that was during Special Forces selection. And by week 3 of the 3-week selection, I was definitely drinking full ORS, and it tasted like milk. It was but that's the only time. It's salt, isn't it? It's salt and sugar and bicarbonate, and it just tastes horrible. So you need to either dilute that or you can add something to that. What ideas do you guys use to make ORS taste palatable? Yeah, lidocaine or gargling lidocaine spray. Doc Hagman used to do that all the time. He would take the lid off of the 2%, have them gargle lidocaine and spit it out. I need to see some research on that. But a lot of things that Doc Hagman did, you got to see the research, but that worked. So, what have you guys done to make ORS taste good? Coconut water. Yeah, there are some good research options on coconut. Do not give coconut water IV. Somebody in the UK that said that's okay. Don't. For the love of science, please don't. Good. Trent, 50% ORS. Yep. Vitamin C tabs. Yep. Good. In the Army, we had this purple stuff. I don't wanna know what was in it, but it made water purple. We used that to make the taste kinda go a little better as well. So, let's talk about diarrhea. This is on page, 131 of the 2nd edition field guide. Treatment, I mean, you have 2 options in life. You hydrate or you die, and you also need to replace electrolytes, and we have a 3 lead on, and we can see if that T wave starts being naughty, then telling us that we have electrolyte imbalance. We can examine the stool and we can give Imodium. So let's talk about that. So there's mild, moderate, and severe. So let's talk about the differences. And I'm going to look at first stools. 1 to 3 stools a day is mild, 3 to 5 stools is moderate, and anything over 5 is severe. It's a good metrics, but we're better than that. We're remote medics, remote nurses. We are going to look at acts of daily living clinically. Clinically, we can look at this guy without having to count poos because does he come to you in your office and says, "Oh, I have diarrhea." Is not affecting his daily activities. This yoke we're talking about right now, it is affecting his daily activities. He's in the tub. But he's kind of on the borderline of disabled as well, isn't it? And he had a fever. All right. Yep. So this guy has severe diarrhea because even though he's only got 3 loose stools, he's disabled and he has a fever. So what do we do? First and foremost, we hydrate and we have a hydration ladder. So drink, have him get ORS. If that doesn't work, we use what IV bags I have available. And if that doesn't work, I'm going to do dermoclysis, and if that doesn't work, I'll do proctolysis. I need to get him hydrated. I can give him loperamide, and we'll talk about loperamide in the next slide. So for mild diarrhea, we're going to hydrate and maybe give him loperamide. That's it. For moderate, this is the point where now he has a change in active daily living. He is not able to maintain himself. We hydrate and we can look at antibiotics as a possibility. And then for severe, we're going to hydrate because that's the number one option. We can do antibiotics and we do not give loperamide. So, and then we'll see bloody stools here. And we can use a guaiac test or urine dipstick test to find blood that we can't see. So occult blood is obviously easy. We've all seen it. It's there. Having a test available to show trace blood is really important for the remote medic. And I'm too lazy to carry a guaiac test, I'll be honest. So I can have one test that does 2 things, the test the urine and test fecal matter. And I wrote about this about 3 years ago. And then somebody in Brazil, veterinarian in Brazil, quoted me on this. And he tested this theory with livestock, and they're 100% accurate on using urine dipstick. So please do use that. But let's talk about loperamide. Oh, sorry. Let's do brat first and then loperamide. So we have a brat diet, and I personally have seen this useful. It works. The bananas, rice, applesauce, and toast seem to be what the messed up digestive tract is able to deal with, but it also gives you electrolytes, gives you carbohydrates. So the brat diet has some good science behind it. Now, let's talk about this. How many of you would give this guy loperamide? You can either give me a thumbs up or you can write an answer. Who's giving him loperamide? Okay, Andy Taylor says no. Stephen Powell. Yeah, question. Go ahead and type in your answer or your question. Yeah, Demetrius says no. Yeah, if you guys have any questions, put them into the chat. All right, my take on loperamide. First and foremost, the science shows BMS is the best at loperamide. They have so many published articles on loperamide, and they say again and again and again, including Cochrane reviews, loperamide does not extend nor does it diminish the disease. So therefore, loperamide is not a medical drug. Loperamide is a social drug. I am going to use loperamide if I need a social reason, such as this guy is getting on a heli. I know the guy's in a helicopter. They'll be very cross with me if I give them this guy that's just going to make the back of their heli look awful. So I will give him loperamide before he goes, or on a commercial flight, or if you're working for the UN and some minister needs to have a meeting with another minister, give him loperamide. We know it doesn't extend the disease and doesn't make it better. It just makes the poo solid. So loperamide's not a bad option. It's just not a medical drug. I told you I'd talk about prolonged field care. I think this is one of the last slides, but you need to deal with this casualties excrement. And if you're in cholera endemic, everything that poo touches is also going to get cholera. So your job as a medic is, maybe keep him in that tub. If that is the best option, keep him in the tub every time he defecates, rinse it off with warm water, dry him off, and keep him in there if he's happy with that. If you're in a clinic, you might need to make this. And these are ready-made cholera cots, but you can make this. You can improvise this. So how this works. So this hole here, basically they're laying, here's the head, here's the feet, and every however many minutes they need to poo, they'll sit up, they'll do the business. It goes right through the hole and gets collected. And then they just lie right back down because that's all they're able to do. They're so weak. And then your job is to get rid of this. And you might need to dig a hole. You might need to burn it. You might need to do something. But what you don't want is that to get in contact with anyone or anything. So in prolonged field care environments, you might need to improvise a cholera crowd. If you're in the jungle in Liberia and with the BBC crew following frogs, I guess you can do this with a hammock. Their hammock, not mine. And I'm going to cut a hole in the hammock so they can use that as a cholera cough. So, and then aggressive hydration and using your hydration ladder. So that is Monday's iCARE scenario. Do you guys have any questions for me?